I would now like to introduce our meeting host, Lenore Boris, Chair of PAC Exec. Lenore.
Thank you. Thank you everyone for your patience. I think you will find the wait is worthwhile. Let me give you a brief overview of today's meeting. The first hour of our meeting today will be devoted to our guest speaker, Karis Grounds. She is Vice President of Health and Community Impact at the 211 San Diego Community Information Exchange. She will be speaking about the power of one, building community-driven networks and sharing key components necessary to build a strong, sustainable network. An inspirational quote comes to mind when we speak about the power of one. Henry Ford said, "Coming together is a beginning, staying together is progress, and working together is success. Together we, working together as a collective group, can increase our impact and multiply the impact we have on our communities." In the last hour of the meeting, Mark Ropiecki, Care Compass Network Executive Director, will be sharing more major updates on the CCN strategic plan, including advancements on the Open and Performance Network, as well as a draft framework for a new program that we think will be of interest to you. So let me turn the program over now to John Mazzello, who will be introducing Karis Grounds, sharing with us her bio information and connecting her message to the CCN strategic plan. In addition, he will provide a little background on his involvement with care management platforms. John?
Thank you, Lenore, and thanks everyone. Good morning. As Lenore mentioned, I'm John Mazzello. I'm Director of Community Services and Program Director of 211 Tompkins Cortland, with the Human Services Coalition of Tompkins County up in Ithaca. Over the past several years, I've had the opportunity to be involved with Care Compass Network in a number of ways, on the PAC Executive Council, on the Cohort Executive Committee, and on the IT and Data Governance Committee, and most recently on the Strategic Planning Working Group. And seeing the evolution of Care Compass Network from all these vantage points has been rewarding. But more importantly for me, looking ahead to where the network can go together, as Lenore mentioned, is extremely exciting. That's why it's my distinct pleasure to introduce this morning our presenter, Karis Grounds from 211 San Diego Community Information Exchange. The network that Karis and her team in San Diego have built offers a multitude of lessons for us as we build Care Compass's own network of clinical and non-clinical partners, of CBOs and of others. So back in 2018, the Human Services Coalition applied to be part of the inaugural cohort of a new mentorship program that was sponsored by Data Across Sectors for Health, or DASH, an initiative launched by the Robert Wood Johnson Foundation. 211 San Diego was one of the mentors. HSC was selected to participate in the program, and it began a year-long mentorship with Karis and her colleagues for us. This was around the same time that we were starting to plan for our own implementation of the care management platform through Care Compass Network. So we were particularly interested and open to learning about how cross-organization data sharing and outcome tracking and more, information sharing for better health and other outcomes was really attainable. But actually, we learned so much more than we were expecting. That mentorship year was really transformational for us. It connected me personally to a group of other organizations around the country talking about building networks, sharing information, particularly from the CBO perspective. All of the mentees had a chance to travel to San Diego for their Community Information Exchange Summit in 2019, and then again virtually in 2020, and meet with Karis and the other folks from San Diego in person. And since then, 211 San Diego has continued to serve as one of the national bright lights, demonstrating how networks of community-based organizations, clinical partners, voluntary groups, and others can work together to support better health outcomes, to create better access to care across services, to better use the information they have for community care planning, and importantly, to strive for more equitable service systems that respect each client or patient as an individual. So, does that sound familiar to anybody? When I heard that Care Compass Network was searching for a speaker to share their experiences building such a network, I didn't hesitate to suggest Karis. As Vice President of Health and Community Impact, Karis Grounds oversees the 211 San Diego Community Information Exchange, supporting the vision, engagement, and integration of what they call the CIE. Through a public health lens, she helps to build relationships and partnerships with health and social service providers to improve coordinated care and health outcomes for the community. Before the launch of the CIE, Karis served as 211's Director of Health and Partner Integration. She developed a regional health navigation program to serve as a hub of information and services for San Diego and Imperial counties. Her team addressed clients' social determinants of health through a phone-based care coordination model, building care plans, coordinating care, and educating clients. Karis has helped to build cross-sector partnerships with 911, with local hospitals, with the county's Health and Human Services Agency, with legal aid organizations, educational-focused organizations, clinics, and more. Prior to working with 211, Karis worked in international and refugee health, helping to improve access to care and preventative services. She's passionate about social determinants of health and advancing holistic health to improve equity locally and nationally. It's my pleasure to welcome Karis as our speaker this morning. Karis.
Thanks, John, for that introduction, and thank you so much for having me here this morning from the West Coast. So I'll be walking you through some slides, a little bit about our community information exchange, and as John mentioned, we've been at this for 10 years, building our community information exchange, and with the interest and pickup, I think, in the state of the field of being able to kind of think about how health and social services really work together, as well as the newest kind of awareness around racial injustice and kind of the opportunities to provide more equitable care. CIEs have kind of become a opportunity for people to think about a practical way to really be able to address some of the systemic issues happening in our community. So although we've been at it for a very, very long time, we're happy to share our successes and recommendations just from our own failures and opportunities, as well as we help other communities to kind of build similar tools and thinking about ways that you approach this concept based on your own local needs. So we'll start by just hopping to the first slide. So just talking a little bit about what the difference between 211 and CIE. So I am a part of 211 San Diego. As many of you know what 211 does, it's traditionally known for like a 3-digit dialing code, 24/7 resource line that really actually supports as a hub to access the community health and social service resources. So often known to have a resource directory and existing relationships with community-based organizations. I started really running our navigation department that worked with clinical to community linkages around starting that work, but 211 is kind of our robust program that provides those direct services, like an access point or a hub to be able to connect those services together. CIE is almost a separate program or service. And so we just want to make sure that there's a differentiation. 211, in our case, was a great opportunity for us to be the backbone of our community information exchange, but we're finding across the nation, it's a whole bunch of different collaboratives. It could be Accountable Communities for Health. It could be some collective impact organization, United Way. So CIE is really looking at the systems change. So it's really about the infrastructure that allows for organizations to work more collaboratively together. Now, 211 is almost like the biggest user of a CIE, but it's not one and the same. CIE is really looking at, as a community, how do we move towards person-centered care? How do we start thinking about interventions differently by understanding the holistic situation that someone's experiencing? How do we better connect people to wellness goals that aren't just focused necessarily on one sector, thinking on more holistic pieces? So it's really like, 211 might have some of the elements or infrastructures that CIE needs. CIE is really about how as a community can we come together and really address these issues. So if you go to the next slide, the way we define a CIE is really there's some core components which I'm going to walk through with you this morning, but it's really an ecosystem, a community-led ecosystem that's made up of multidisciplinary network partners, using a shared language, a resource database, and integrated technology platforms to deliver community care planning. I know those are a lot of large words, so we're going to break those down a little bit, but the idea is to really be thinking about things from a micro, meso, macro standpoint. So like, how does the individual get served differently for the needs that they have? How does, as an agency to agency, how do health and social services really start working better together, or government, for-profit agencies? And then as a community, how do we start using information to make decisions about what the needs are and the resources that need to be allocated? So the idea is that we start working in a more proactive way and a more holistic, person-centered, trauma-informed way to really get at the core roots of a lot of our issues like anti-racism and equity. So if you go to the next slide, some of the defining concepts that we kind of think about when we're looking at our CIE, and what John might have alluded to, sometimes the core of the outcome of what you're trying to get to gets lost in the technology or like the actions that are required to get there. And so what we like to define is really like, what are the concepts or elements that we're really trying to think about when we're building a CIE? So these are just some core pieces. They're kind of pulled out of some of that definition we talked about, but really it's building trust and capacity within community. It's cultivating an understanding of like root causes of resource gaps, thinking about those things. And it's enabling cross-sector collaboration. It's designed to uplift the providing agencies to the communities that they experience the most disparities and inequities. It's community-led and stewarded. So we sometimes want to pull out this concept because sometimes I think we all get focused on like cost savings and like, you know, outcomes and all these like more, which are absolutely important and actually absolutely need to be there. But if we don't define the vision of what we're really trying to do, sometimes those get lost in like what it's meant to be as a community. So we really, in this last year, have really focused on like, how do we redefine the concepts and elements that are really key to making a CIE successful and work? And how do we really think about these concepts in the design and initial elements when we come together as a community? So if you go to the next slide, so again, person-centered care, the goal of really doing this work is person-centered care. And the way I've described this before is like, when you think about patient-centered care, which I'm sure everyone in the healthcare field has thought about this, you think about the patient in the four walls of your own institution, and you're thinking about, okay, if I cross between departments, how am I gonna make sure that this individual doesn't have to retell their story? But if you think about it as a system of care, as a community, the same person probably experiencing that when they go to the county or to get benefits, or they go to their FQHC or federally qualified health center to access healthcare services, or they go to the shelter to access housing. They're experiencing that same sort of experience that people are trying to provide in their own four walls in the community, where they're having to retell their story, they're having to share their documents over and over again. No one really, they've already tried this service 25 times, but it doesn't matter because you're sending them the same referral again. So really person-centered care is about centering the individual in the community and the services that they're accessing, and really tailoring what those needs are based on their holistic situation, and not based on the organization or institution they're accessing it from, but really about the needs of that individual as they're accessing services from you or trying to be supported within the community. So we use these kind of 14 domains to really think about what someone's holistic needs are. So if you go to the next slide, we also just want to recognize that this is challenging. And I think you guys have already started going down the path of what that means. And so some of the common challenges that we really kind of want to just lay out there is thinking about navigating power dynamics. So that is something, as we look with health and social services, traditionally institutions have been a part of it, which are important, and that's part of our system of care. But how do we center community voice? How do we center individuals in the community that are accessing these services? Really thinking about how do we create a shared table for everyone to kind of come and talk through. We also want to recognize the value proposition is important. And I was kind of alluding to that with the concepts and elements that we think that are key to be able to move this work forward. But the value proposition is different for every sector. And so in social services, what's valuable to housing or homelessness is not necessarily the same as food insecurity, is not necessarily the same as social isolation. The metrics, the outcomes are different for each one of those CBO organizations. And then on the healthcare side, you think about health plans have different requirements than hospitals, have different requirements than health centers, and so on and so forth. So the value proposition, it's although there can be some standards to be able to kind of look at what's the value, you're really trying to, you have to really think about value propositions based on each different sector, even government. Same thing, there's different outcomes and values that they find and that they need to be able to deliver on. So being able to really think about what's the compelling value proposition that can really meet the needs of all these different organizations that are coming together to address this, as well as what are some key pieces that will be helpful across these different sectors. So that's one of the key challenges I think that as you move a CIE along, you need to kind of be considering. Establishing a shared language is something that we've been exploring for a long time. And that's really not necessarily saying like, okay, everybody has to do the same SDOH screener or everybody has to use the exact same language. It's about what are the key elements across sectors that we can all, measure jointly. And that could be thinking about the way I think about it is like a scorecard or something. Is there a way that you could potentially, it doesn't matter how you ask the question, but there's some data fields that really align, whether that be homelessness status or whether that be food insecurity or things like that, that really you could create a shared language to understand, okay, when this person presents at an organization or it has some needs, we're able to communicate across our different sectors on what those needs might be. And we're thinking about it again in a holistic way. And I think that's also not only just from the individual data field standpoint, but that's also just like when you think about value propositions and outcomes for individuals and what you're measuring for success. I think that is also where sometimes things get lost in translation as you're trying to work across sectors. What you're measuring here and what you're measuring here don't necessarily feel like they align, but it's really the same language. It's just that in healthcare, we say it this way, in social services, we say it this way. So being able to kind of, okay, let's redefine some of the, like even social determinants of health is something that social services it's been around for 50 years. In social services, we've been doing this work for a long time, but healthcare has defined it as social determinants of health. So, okay, what do we mean when we're saying this? We're probably saying the same thing, but it's a matter of, creating those, understanding that when we're saying this, we're meaning this. And so being able to create that shared language across a community is really, really important. Establishing and redesigning practices and processes for optimal engagement. This is really saying that we've been at this, as I mentioned, for 10 years. We're figuring it out. It's not like, here's the right way to build a CIE. We have some concepts and tools, but being able to be agile with your community needs. So for example, as new initiatives come out or new waivers or new Medicaid funding or new needs populate, you're gonna have to respond differently. So the idea that this one thing we created 2 years ago is gonna be able to be applied, like we're constantly reinventing the way that we've built this. And that's because we need an infrastructure just like all of us evolve as people, our communities evolve and our needs evolve. And so being able to really build things in a way that like, okay, we're building this for this iteration, knowing that it's in pencil and, we're going to erase some things and we're going to redo it. So having that really agile process, especially as you're working with cross sectors where for health, for social services, funding can completely change their vision and mission and opportunities to engage, being able to really readdress those needs in any points in time. So those are just some things we wanted to point out early on to say like, these are some core things you need to be thinking about as you're building out your CIE. So if you go to the next slide, we also just wanted to kind of outline the fact that there's not only challenges, but like this is a cycle of movement. So we built a CIE and I call it like an ocean, and there's a lot of pools that pop up. And so can we build, not necessarily everybody needs to build an ocean up front and then try to, bring everything in. Some communities are starting to bring pools and then bringing those pools together. So we really that there's a phased approach to building a CIE, and it really starts with buy-in and community engagement. And I think sometimes people start with technology, but a lot of times if we're not focused on like what the capacity is within our community and what the buy-in is and what the engagement is on this, you might start with the technology and get a little far in some ways to be able to bring organizations on, but the root needs and issues of the community, they're not bought in necessarily to this product or technology. And it's really not about the technology. It's about engaging as a community and community-based organizations and social services and healthcare and for-profit and government all together in a different way than you've had before. And so being able to think about this as like stages or phases to the work is that really you need to start with that type of engagement. So people are brought and they feel like they're part of this vision and they feel part of this change. As I talked about a little bit, like starting to share records, starting to share information, being able to think about data standards, governance. Then you can start moving to referrals and more consistent data sharing, shared language. So these are really thinking about the various phases that's required to be able to really move up a CIE. And so again, so the buy-in and community engagement is really important, being able to really start sharing records across systems. So can you, looking at master patient index or looking at a way that you can communicate the way that healthcare defines someone's first name, last name, date of birth, social security number is in social services might be different than healthcare. So being able to really create ways in which a shared record can be communicated across different sectors. really thinking about the way that data standards and governance, like who owns the data, what type of standards, how are you going to be able to, when you have data coming in from multiple sources, what gets validated above one another, being able to look at data standards across your community so that you guys are all agreeing to similar ways of sharing that information as well as governing that information. Then start moving into looking at referrals and data sharing. What does it mean to actually make referrals? Are you thinking about it from from a just referral standpoint? Are you integrating data from your homeless management information system or from your food services or from other CBO organizations to have a more robust record of what's going on? So thinking about then creating shared language to be able to map that across the different sectors. And then really thinking about an integrated client record. So those data sources and those referral information start actually being leveraged to see someone's longitudinal client record and know what's going on. And we are not even, when we think about our own community information exchange that's been around for a long, long time, creating a shared care plan and having more community care planning is not even something we've gotten to yet. And that's because we're still at this phase here, phase 6 of really having an integrated record, but like who owns the record and who navigates that person through all these social services. It's not fully fleshed out yet. We're still working through that as a community to be able to actually share goals across housing, across food services, across healthcare. And so that's really where we're evolving as a community. What does that look like? And what does that mean to be able to address it that way? And can we start tasking different people across different sectors or organizations to be able to do that? That's kind of the future state of what we're looking at. But again, knowing that it's not kind of one size or at one point in time, you're kind of done. It's evolving to the point of being able to really think about this as community care plan. Can we come together as a community to actually start supporting this individual in a holistic way? So if you go to the next slide, when I'm really talking about a little bit more about the community information exchange partners, so we have 105 organizations, I believe at this point. But again, it's across sectors. So it's healthcare, social services, it's broken down by a combination of different sectors. And again, it's departments, it's entire organizations that everyone's using it in a different way. And they're using it for different needs. In healthcare, a lot of times we see it for complex care patients. In social services, we sometimes see it for shared initiatives where everyone's kind of tasked at addressing those issues. But it ranges from government sectors to for-profit to social services to healthcare. So that's kind of a little snippet of what it looks like as an entire community. So from those kind of partner organizations, the CIE Stewardship Framework, because I talked a little bit about the way that our governance structure is set up, it's led and community governed. So 211 is its own agency. CIE is stewarded by this shared governance structure. We have a CIE advisory board that's made up of participants of the CIE and kind of collaborative based organizations that are anywhere from CIE or associations. So like our hospital association or our federally qualified health center association or our United Ways, our collective ACHs, those kind of organizations sit on that advisory board to really look at the strategic plan of what we are going to move down as we build the CIE and continually meet on a monthly basis to look at opportunities to be able to leverage that in a more cohesive way. Then we have network partner meetings and community voice meetings. So those are network partner meetings of those 105 organizations. Directors and managers come on a monthly basis to really talk about how do you use it? How do you implement it? What's working? What's not working? What initiatives can we think about for implementations? Those kind of things are all part of our network partner meetings, as well as we have a community voice meeting that's really thinking about how do we center community members, like individuals, constituents, patients, however you might call it, thinking about how do you include community voice and make sure that their voices are representative of what their needs are. And that could even look like the community voice group looks at like, okay, how do you want your data shared? How do you feel comfortable consenting into having your information shared? How do you, what is your experiencing accessing services? Thinking about those type of things that can really shift the way that we build the system to be able to support them. And then we have from our network partner, so from that community voice meeting, so we have a community advisory board that's actually made up of community members that are giving us that kind of sharing that information to be able to kind of redesign how we're doing that. So community voice is a combination of our network partner meeting as well as community members in the community. And then we have a solely designated community member advisory board that's actually helping to advise all sectors of our, all sectors and all infrastructure of our CIE Stewardship Framework. We also have user experience work groups, affinity groups that are focused on specific target populations or local initiatives. For example, like ACEs is a big one, so adverse childhood experiences, multi-generational families. Those type of affinity groups help to spur use cases within the CIE to be leveraged. We also have policy working group that really looks at like, what are the ethics and standards? Like, how do we want to, what type of organizations should be able to join? What are they agreeing to? So these are ways in which our community feels trusted. As I talk about like what's trust and cultivating capacity and being able to understand that this infrastructure, having it be community led and stewarded, allows for that information to continue to flow up to the top to make strategic decisions that is the best for our community. And again, it creates a seat for everybody at the table. How do you want to be engaged? How do you want to participate in this? And so again, we want to make sure everything's driven by community voice and community members, that we want to center that. But having the stewardship framework really allows for that to flow through all elements of our infrastructure from a practical side and a conceptual side. So if you go to the next slide, when we really say community-driven approach to care too, we just want to really highlight the idea that community stewardship, again, you guys kind of saw leadership at all levels. We want to make sure that everything's informed by the community needs, that we're testing that on and on. Community ownership, we want to make sure that there's, not only do we have the community voice advisory board, as you guys saw, but how do we make choices? Like, how are you opting in to know how you have to opt in to know your information is shared. We don't have an opt-out method. We want to make sure people understand how their information is being shared. We want to, that's kind of changing and evolving over time if people understand the way that data could be used, but can we make sure that that input is always being recognized and that it feels like community members that are participating also have ownership in that process and the information and the way it's being used or interpreted. That even comes down to the way that we interpret data sets. Like, we're making these assumptions around how homeless and impacting these certain races. Can we ask our community voice and our community council to see, is this the way that we should be interpreting this? Is this the right language? The fact that it's tailored by the community. So again, we have it customized as we use initiatives to really drive the way that we leverage the system. We tailor that to be able to do new screening tools or new information or new data integration partners. So different organizations can share data. We can customize it based on the needs of our community. I think there's a lot of standards like out of the box technology can be able to provide, but really you need to customize it from your own community and let the users really lead that. And so that's been a core process to our system, as well as integrated. So one size does not fit all. Again, where our focus is really about integrating data from multiple sources, being able to look at a longitudinal client record. That information really, again, you can start seeing how many individuals are actually accessing services from multiple different organizations, but also being able to follow up from where that last person took off from another organization, as well as like dual data entry. All of those challenges really, when you start thinking about it from an integrated process, kind of alleviate some of those challenges that I think occur, especially from the social services side. So if we go to the next slide, these are the 5 core components that I've been talking about a little bit throughout this whole presentation, but these are the kind of core concepts or pieces that really make up what a CIE is. So I already talked about the network partners and our kind of stewardship infrastructure that allows for us to have regular feedback from our different organizations. But again, we have standard contracts, we have standard language to be able to kind of consent individuals in. We're able to have a governance structure that allows for continual improvement in process. we've created those 14 social determinants of health to be able to look at individuals. And I think this is a little bit different from a binary standpoint, because I think sometimes healthcare thinks about things as black and white, I'm homeless or not homeless, but our shared language really allows us to conceptually think about, okay, I might be homeless, and then I also, I'm on parole, and I have these additional issues that might be going on that makes it more challenging for me to get housing than somebody that is in a different situation. So being able to kind of look at the contextual issues of what's going on with that individual to make sure that we're addressing or tailoring our services based on that full understanding of what their situation is. Bidirectional closed loop referrals. So we have that updated resource directory from 211 that we leverage, and then we're able to close the loop on those referrals to be able to communicate about needs, to be able to proactively reach out to those organizations and not expect the individual to follow up on that. The technology platform, I think I've been talking about a lot, but again, it's integrated technology platforms that ingest information from multiple different sources to be able to kind of look at that holistic need. And then there's really the opportunity to do predictive analytics or opportunities to look at where can we improve as a community, where can we start seeing that all the individuals that are in the homeless management information system have also these health concerns and also are accessing the food bank, and where can we, and maybe going to jail. Those are all things that then by having it integrated, we can start making more comprehensive and thoughtful decisions by understanding the whole situation. And so the future of this work, or what's currently happening, is this longitudinal client record that we're all like an integrated platform that we can all leverage. And the future of that is really looking at community care planning and how do we actually cross-sector collaboration in a more holistic approach. So if you go to the next slide, this is just to give a little flavor of what it looks like in the system. So again, we have data points that live on the left-hand side that are really about who the individual is. You can hover over any data point and see a history, an auto history of where the information has been populated from. So that might be helpful with an address or phone number to be able to see where they previously accessed. We have our domain history of being able to see what assessments have been done by different organizations or what you can see a color coding that's associated with risk. We have care teams, so where an individual currently is accessing services through program enrollment, but also who's working with them, so you can directly contact an organization for follow-up. That's been super helpful for discharge planning as hospitals are trying to get individuals in the out of the hospital. You can see through the HMIS integration that someone's already at this shelter bed, and they can call that organization to follow up with that individual or come pick them up. In some cases, the homeless outreach workers actually come into the hospital and can pick them up. So there's a lot of ways that this gets leveraged. And if you go to the next slide, because I know we're kind of short on time, this is really looking at our referral platform and how the system kind of looks to be able to actually make direct referrals across an organization, accept referrals, send them over. And the next slide, I think, talks a little bit about some of our use cases that we leverage it for. So again, searching patient members to see the historical use of social services and being able to tailor that. I think that's been an interesting shift for our community, is changing interventions based on what an individual's needs are. And not everybody knows how to do that necessarily yet, because everyone's so focused on their own programs or their own services. But that's been really interesting to kind of be able to kind of think about how would you, now that you know this information, how do you do things a little bit differently? So those are a lot of lessons learned that through our network partner meetings are shared. And we have little affinity groups where organizations are actually working together around, oh, I tried this intervention, or this is information I didn't know I had before. How do I do, how do I think about the patient now that I know that they had a history of this or have already tried this? Can I approach something a little bit differently? Making referrals to external community and healthcare organizations. I think that's probably the main concept that most people think of. So being able to make those direct referrals. Surprisingly, in San Diego, because we started as an integrated technology platform. We didn't start as a referral platform. That was something that was more recent. That has been, we still, of course, have a huge number of direct referrals, but the system's more often used just to look at the history than to do those direct referrals. But that's a huge use case to be able to actually track those, to be more proactive, to start looking at when we have limited resources in our community for housing, rental assistance or beds or utility assistance. CIE can be leveraged to be able to make those referrals and be able to communicate across the network this person access these services, so that we can, with those limited resources, make sure that the individuals that need it the most are getting it, as well as people aren't getting it, duplicating those services multiple times. We used it for shared screening and prioritization of resources. So again, as I was mentioning, be able to not only screen for those needs, but then also prioritize who might be able to get it. Use the acuity measures. Can you see that someone's already been to the hospital 6 times? Does that then change that their access to services, or they've already been into jail, they might be qualified for a different case management program because of that. So being able to look at that history to actually prioritize those needs or ensure that those programs that they could qualify for they're getting enrolled for. And then also just like receiving alerts. So as a care team member, you can start getting alerts if you've missed an appointment or you've been to the ER. Those are all ways that we can start working more together collectively as a community to address those, the patient's needs. So we move to the next slide. And this is just an example of some of the workflows that, because of the community engagement, I think that as we're lessons learned around what it looks like and how does it actually flow out, we're actually looking at specific use cases and like doing the workflows of like, at what point could you leverage CIE and when could you make a referral? And at what point does this make sense? And that makes sense. So that's actually the kind of work that's needed for systems change, right? It actually requires you to look at an individual's organization and think about the way that they're doing services. And then at what point in time does it make sense to leverage this information to do a better or different job? And so this is just a little snapshot into like one of our hundreds of examples of what it looks like, but this is what true engagement looks like, is actually stepping in and working with those organizations to really think about, okay, at what point in time does this make sense? Where could this be leveraged? Where could you make referrals to outside organizations? When can you start collaborating? And so I think that's been where we've seen some exciting examples. This is from a Center for Disease Control project that we have around heart disease and stroke, but it was the opportunity to really start referring to lifestyle change programs, which these FQHCs didn't have capacity to do. And now people that need it can actually get connected via the CIE to those resources. So if you go to the next slide, this is just kind of a lookout of what it means around outcomes, outputs, outcomes, and impact. And so the way that we say this is we've still been out. I mean, we've been at this for a long time, and we have, of course, shown cost savings and return on investment and all those kind of things. But, you know, outputs is still a huge part of what we're doing. So we have like the amount of individuals that are looked up, the organizations that are data sharing, the ones that are, how many people are consenting in. We have over 200,000 individuals that have consented in to have their information shared. Those direct referrals are all, you know, part of the puzzle to be able to really start using the system and start collaborating to actually change systems, right? And then we can start really looking at what does an improved state of wellness look like? And that doesn't necessarily just have to be around the healthcare costs, but it could also be on social vulnerabilities, like that they're not food insecurity anymore, or they don't need, they went from needing food today to being on a benefit program that allows for them to get food regularly, to be able to be eating nutritious food. So how do you start thinking about an individual from a more self-sufficiency or a holistic standpoint instead of just like food insecure, not food insecure? And so that's really how we're trying to measure a state of wellness, being able to move from really focused domain-specific interventions to person-centered. That's another thing we're measuring. And then how do we start looking at changes in your interventions, interactions with people, and being able to look at more trauma-informed care as a community, more person-centered care as a community? How do we start? What does that mean as that gets put into action? And so again, we are really looking at these high-level things: improvement in health indicators, advancing quality of life, and addressing those inequities. And again, the inequities, I think, has become more of a core piece of our puzzle, and thinking about equity and anti-racism as a way to, can we start splicing this data? Because we have this massive amount of data, we can actually start looking at specific populations of people, or certain zip codes, or gender, or race, and start actually using the information to make decisions as a community, which before we had some of this data, but more in like program specific areas, like, you know, maybe the housing group had something, or this certain healthcare data had this. But with the CIE, we can start looking at significant inequities across a large amount of community with a lot of different data to actually start informing the way that we provide care, which is really exciting and really impacts our investments and our resource allocation as we're trying to build up our community capacity as well as support the individuals most in need. If you go to the next slide, so I already kind of alluded to this. I think if you hit a couple more, it's going to pop up a couple other images. But so this is really looking at some of the publications and the different work we've been doing. If you go to CIE San Diego on our website in the news, we publish all these articles as use cases to be able to help other communities really think about it. And again, it's not just us. A lot of communities are building community information exchange and are leveraging it for different ways. But we've seen some ROI specifically through some of our cohorts looking at reduction in EMS transports and health and hospital admissions, that really looking at the cost savings around that. But CIE has been leveraged for a lot of different ways. And we know that the value and the ROI of this is not just in the cost savings, but it's also in the impact of the people that we're surveying and their lives. And what does that mean for wellness? And so that's something we also do as part of our community voice is like, what does success mean for a community member? And what's valuable to what do you want to get to, or what do you want to do, and what are your goals? And so how do we start centering that as part of our outcomes as well is really important to us. If you move to the next slide, these are just some recommendations that we have as you guys kind of go through this journey, but really understanding the worth and value of community partners and their unique perspectives. I think this is the challenging part of it, right? Is that there's so many different organizations and so many different sectors, but again, through your governance structure, you're really allowing for that worth and value to be able to hear all those voices and have those inform the way that you're actually approaching this work. And so you know, sometimes we have sector specific groups kind of come together and help make decisions around how we screen for social isolation, or how do we start looking at refugee communities. And so those are all, that might not be the massive amounts, but those all inform our approach and the way that we think about things. And we always just want to make sure that we value the fact that that there's a capacity need and an infrastructure need to be able to support these community partners to be able to do this work. Knowing strategic partnerships are critical to community coordination and multi-sector implementation. So again, this is not only a practical application, but there's a strategic element to this. So it's not only about funding and infrastructure and grants and all those things, but it's also about like, how do we support what's existing in our community? What are some of the existing challenges? Implementation has to be supported for everybody. So really looking at, you know, that's where we have the hospital association, or we have our United Ways that really create these, they have more collective impact, like input into this work. And so how do we create those strategic partnerships so that we can support those organizations in supporting all the organizations that they are helping to steward and support? So those strategic partnerships are really, really important to actually have action. Because it's one thing if you have a bunch of organizations on a system, but if no one's actually using it or find it valuable, then it doesn't really work. Understanding your audience and tailoring the values to the values of those organizations. I think that that's also another piece of the puzzle, is just making sure that there's buy-in. What's valuable to you? How do we actually make sure that this is, these outcomes are going to support your processes? Those kind of things are really about, I mean, it's not only about systems change, but how do we align what that systems change means to be able to actually create value? So maybe that is, looking at the metrics they already are capturing for grants or for HUD or for their food reporting, and how could CIE support that? And so we've even looked at that with, like, there's some HUD requirements that show that you need to make sure someone's still housed after 2 years. And we can now use our utility data to see if somebody's actually housed since they're in the CIE, we can actually use that data to say, hey, these many people are housed after 2 years, and they can report that to HUD to actually allow for additional funding or to continue funding or to show their success through that. So being able to understand different organizations' needs and how CIE can actually support that. And then again, taking the agile process, things change over time. We evolve every day, all day. Not to say that there's not a core infrastructure to everything we're doing, but all the input from community, because we have this infrastructure allows for that feedback. It's amazing the ideas that people have and the things that can be improved. And so being open and creating the infrastructure to allow for that really informs our processes and creates a meaningful strategic plan, not only for our community organizations, but for our community members, because we're centering them through that whole process. So I think we're going to pop over to a couple questions, poll questions. I don't know if we want to open it up for other questions before then. Do we want to just pop in? Okay, let's do a couple polling questions real quick. What are some of the things that you think your community needs to further understand in building out a network? Great. So this is kind of, I mean, these are kind of the 4 core components that I think we always think about. And happy to answer some questions specifically about sustainability if that is the #1 response. Awesome. All right. So we have sustainability as kind of thinking about what that means. And I don't know if we want me to talk a little bit about what sustainability is. Okay. So we think about sustainability a couple ways. The way that our CIE San Diego is set up is called a braided or blending funding model. So we sometimes find that if it's one health institution or one organization that's funding it, it doesn't necessarily become as successful because that one organization is thinking about it. So a blended or braiding funding model means it comes from a whole bunch of different sources. So we look about it from, we have CIE memberships, which means health plans and hospitals pay in to have access to the data, to be a participant of it. It's free for community-based organizations and nonprofits. But we do have a membership rate for healthcare and for-profit organizations. We also have contracts where we're actually leveraging for a lot of our collective impact like grants that our community goes for. They write in the CIE to actually be that infrastructure piece. So for example, we have a Partners in Prevention network that's of 50 organizations that are trying to better address multi-generational needs of youth and families. And so the infrastructure in which it's leveraged is CIE. So CIE is written into grants to be able to actually be the coordinating hub across those organizations. We also have philanthropy foundations that are funding this as well. So we have, it's a collective of funding. Government funds into it. So we have our county that actually leverages it. We have a bi-directional connection with our county system so that you can see when someone already has benefits, those kind of things. So that's also funded into the infrastructure. Our cities pay into the infrastructure. So it's really not one sector or one organization, it's a collective. And so that's really where the stewardship framework is key, because when you have all those seats at the table that are really thinking about how this can be leveraged, it allows for, instead of building 15 different systems to be able to address a need, we're actually leveraging one system to be able to support those and tailoring those based on those. So that's a little bit of the way that our sustainability has evolved over time. Again, it started with like a foundational one-time kind of build this out, and then we're able to build an infrastructure where we're sustainable now because of our blended funding model.
Karis, I had a question come in.
Okay, great.
It says, I'm wondering how the funding is shared amongst partners.
That's a great question. Great point. So at this point in time, there's no cost to community-based organizations or federally qualified health centers. But the way that we've established, it's not a general cost for all, but we kind of have like a broker model where when we get grants, we provide participation fees or contracting directly to the community-based organizations that are leveraging the platform. So that allows for community-based organizations, when they are adopting the platform or re-engineering their workflows or those kind of things, we can actually fund directly to the community-based organizations to re-engineer that work. And then we're looking to future models to be able to have that be like can referrals from healthcare be funded through this system to be able to actually pay the community-based organizations? Can this be the infrastructure? We're looking at billing. As you guys know, there's new Z codes and billing codes that are come out of Gravity Project to be able to actually designate certain social needs by diagnosis and be able to actually track that differently. Can we start leveraging these new infrastructures to actually be able to support the organizations that are doing the work? So we have some infrastructure now where we're actually supporting the funding of those community-based organizations, but ideally there's ways in the future in which we could do it in a more robust way as new billing and funding sources kind of come out. And I know that varies state by state. Some of the waivers, like in some of the other communities we've looked at, CMS has allowed for organizations to get paid for it. Fortunately, in California, it's a little bit different. We have some CalAIM is a new program that's kind of looking at those waivers, but it really varies on state by state. I've seen other communities be able to fund fully community-based organizations to participate. Oh, sorry, Alexa.
Nope, that's okay. I was just going to say there's another question in the chat box. I don't know if you have it up. It says, are any health information exchange organizations involved? And if so, to what extent?
Yeah, so we have a direct connection with our health information exchange. It's called San Diego Health Connect. So we have a direct API integration. Right now, when you log into the HIE, there's actually a CIE tab that you can hit. And so when an individual is in the HIE and CIE, you can actually see a little snippet of what their social needs are. And then you can directly link into the CIE from that platform. We haven't fully figured out, just because I think we're still figuring out what's the right amount of information for healthcare. And I think that's totally varied based on who you're talking to. Like a physician might want to see this much information. If you're a social worker, you want to see this much information. So that's kind of our process of thinking through how HIE and CIE could be leveraged, is really like, can we have a little snippet? And then if you want to learn more, log in here. So that's the way that we've kind of leveraged it so far, but we do have a direct connection. We have clinical measures that are in the CIE now. We have direct APIs with a few of our FQHCs where you can actually make orders to social service organizations from their EHR, just like they make a prescription assistance referral. They could also make a referral to to social service providers like food banks and things like that. So that's a new thing that we've just actually launched in the last few months. And then based on your role-based permission, you can see clinical measures in the CIE. And so we do have a direct API with our HIE as well as our healthcare providers too. EMS, we have a connection with, so when people are transported, that's really helpful to be able to follow up. If you're a case manager at a shelter, then you know that this person's at this hospital and can follow up with them. Those kind of things are also leveraged.
Are there any other questions?
Lenore, this is Pam. I just want to say, Karis and John, thank you so much. Hallelujah. You get it. You speak our language. You have just described TWO. For those of you that don't know, that's the integrated delivery system that started in this journey of Medicaid redesign, plus the innovation genius of Care Compass Network, plus the cohort management program, and that critical piece, what comes next. You speak our language. On behalf of the National Association of Community Health Workers, thank you. You speak our language. You get it. We get you. And also the National Association of Social Work. And we've got to keep those core principles, competencies, code of ethics moving forward, because you've got all those key elements. You are a gift. Thank you, Care Compass, for bringing her to us.
Oh, what a nice segue you provided, Pam. First, Carissa, thank you so much. It was very informative. And now I want to invite John back, because he's going to show that connection from the things you talked about to what Care Compass is doing to try and get to where you are. So John?
All right, well, thanks, Karis, and thanks, Lenore, and thanks, Pam, for essentially doing my slide for me. So I'll just take a minute and, appreciate the kind of inspirational journey that Karis has shared from their, 10 years ago to now, and all the work that really went into that. And I've just been asked to take the core components of the CIE that Karis has described and just kind of connect them back to the work that Care Compass has done. So obviously, we've gone in, slightly different directions, I think, and are in different places with each of these, but really, I think that each of these areas has had some conversation, some work, some emphasis over the last several years in the Care Compass work. And really now the challenge is for us to think about, where do we put our energies into the future? Where do we as a network look to enhance the work that we're doing? So initially up there in the network partnership area, this is certainly an area where Care Compass has done a lot of work, right? Developing the relationships and the agreements, developing a governance model that works for partners as well as for the umbrella organization. So there's been lots going on there, and that ongoing engagement of which this meeting is part, but certainly the work of many of the staff and the partners as well. The shared language here piece is an interesting one, because I think that particularly during the district projects and the cohort management program, so much of the energy was around talking about initiatives with common goals, with common outputs and outcomes, and particularly with common measures, really laying the groundwork for future partnership. So I think there's an area where the demonstration of that importance of the shared language really has come through. For the bidirectional closed loop referrals and the technology platform data integration, certainly the technology work that the folks at Care Compass have done as an organization, as well as many of the partners, has been significant. And I think, to date, while we haven't gone to quite the same direction as Karis has described, there has been so much energy around the care management platforms, the population health platform, the work that Care Compass has done supporting telemedicine, particularly the population health department's work around synthesizing that vast amount of information that's generated through Care Compass initiatives or tracked by partners, and using that to drive decision making. I think there's been just so much that has happened here. And finally, the community care planning. I mean, this to me, and if you've been in meetings with me where people are going on about closed loop referrals, which is like the bread and butter of 2-on-1, right? I've often said, yeah, but that's like step one. Let's get to where we really want to be. The community care planning for me is really where it is, right? Where we want to be as a community and as providers in general, working together to think about the needs of our community in a holistic way, collaborating together, in our communities individually and really across the region. And this is where I really think one of the hallmarks of Care Compass's work has been, right? Looking at things from the partner as well as the patient or client perspective, thinking about how we can work together, and then starting to build the systems where that work can be facilitated. So of course, that's a long-term challenge. That's a long-term goal. And there's much to do, but I really want to, second what others have said. Really appreciate, Karis, you coming and sharing your journey and your vision. I have been talking about the 2-on-1 San Diego model wherever I go over the past few years, and I appreciative to Dash and to you for the opportunity to fly, small town Ithaca guy out to California to see your system in person. And I appreciate you joining us and for all the support you've provided. So with that, I will turn it back over to Lenore, and we will continue on with the meeting.
All right, thank you, John. We always knew when Care Compass was created and at the start of Disrupt that 5 years would not be enough for us to create the kind of integrated delivery system that would serve the patient and have it patient-centered. So we have been putting components together, and you can hear that we're on the right track for putting them together to really create an effective organization that's going to meet not just the medical needs, but the social determinant and other needs of the patient population we're serving. So I want to invite Mark Ropiecki now, the Executive Director of Care Compass Network, to give you an update on what the strategic planning group has been talking about to help propel us in the direction that we're headed. So Mark?
Yep, thanks, Lenore, and thanks, John and team, for connecting us with Karis. I know we've spent a lot of time doing, over the past few years, PPS to PPS compare and try to understand what's been happening across New York State, and it's refreshing to see what's been happening literally all the way across the country. So thanks for joining us this morning, Karis. I'm going to go through a few updates from Care Compass Network. We can go to the next slide here. And one is just a moment of appreciation. I saw Rob Lawless on the meeting earlier. We did have some changes at our governance structure earlier this year. Back in April, we had a completion of term for Jack Sallow and Rob Lawless. Rob, you're on the phone today, so thank you so much for your service on the CCN board. Greatly appreciated. Completed 6 years on the CCN board, which is hard to believe. And so completing that term, we had some vacancies open. Happy to announce, and she's on the line here with us today, Lenore Boris was one of the slate of 3 members voted in. We're announcing here also Dr. Scopoletti's retirement. If you've not heard it, Dr. Scopoletti did announce his retirement earlier this year. So we do want to appreciate him as well, although he is currently still a board member. But here you can see the spread, and there's a previous discussion about governance and having representation and how does that work. And I think if you take a moment to pause and look at the representation that we have here, we have physicians with health systems. We have a physician with an independent practice, Endwell Family. We have the health departments. We have community-based organizations, a pretty wide and well-represented spread. Lenore opened up the meeting as chair of the PAC Executive Council. So I do want to just remind the group that the PAC Executive Council is a group of, I'll call them community champions that get together and represent the broader stakeholder group. In many instances, we've had members of PAC Exec get reviewed and considered to be members of the board of directors. So if we do have vacancies in the PAC Executive Council, we would send notices out to you. And I encourage you, if you have an interest in joining PAC Executive Council, it's always helpful to give Lenore that courtesy heads up so that when the vacancies come, we know who has the interest and the availability. So I'm seeing a lot of congratulations in the chat as well. We can go to the next slide here. All right, so pilot program framework. I'm so excited to come to you today and say that Tuesday of this week, our board met and approved the next program that we're going to be rolling out. It's been quite a while, quite a number of months, lots of planning. And before I get into the details, and here's the mechanisms, it's a $4 million pilot program that's seeking to connect our CBO partners with VBP contracts. And so this is our first foray into this sort of sustainability program. I'm going to go through some of the mechanisms and we'll go through maybe some Q&A on the back end. But this was a really exciting development. Before I do dive into this, I also want to thank the group. I'm not going to pull up the names and everything, but we do have a representation of partners that have been supporting us with strategic planning. And so this is just one output from that work group, but they've been meeting every 2 weeks since the fall to come together and give us some ground level advisement on all these things. So thank you so much to that group. So we can go to the next slide here. The big question posed to us was, how do we at some point begin to titrate off of relying on the DSRIP funds and connect to non-DSRIP revenue sources? That's one key question. We also look at it and say, how can we continue to build on all of the learnings? Pam made reference to Project 2AI. We've had projects up and down the alphabet. We've had the cohort program, the MIP program, a lot of innovation programs. So how do we take all these learnings from the last 5-6 years and find a way to extend them and move them forward. The basis of this new pilot program would be that CCN would connect and collaborate with organizations that have VBP contracts in place today. And we would look to identify for those VBP contracts, where are metrics not being met? And we want to support the ability of our VBP contracting partners to meet and close the metrics that they have under contract by organizing what I would call a CBO or SDOH network to help them close those gaps in measures. So we can go to the next slide here. I'm speaking at a higher level to it. So some of the learnings from the cohort program was that this is great. We've learned that we can organize and integrate clinical and social providers of care around defined populations. In that case, it was limited to 200 people. In that case, it was limited to a contracting phase. We wanted to find a way to lift and grow beyond that. So in this pilot program, it's not limited to a set number of individuals. It's set to the number of, I'll say, covered lives in a specific contract. So each one of these might be a little bit different based on whatever the specific needs are from the VBP contract holder. As well as the term. We might find terms that are 1-year terms, 2-year terms, or longer. And that's something also that the partners were really advocating for. How can we find ways to do initiatives that maybe have a longer scope of work to them? This is a program that CCN would be able to pay, if it was for a Medicaid contract, we'd be able to pay that CBO network on whatever the basis is that's appropriate for the interventions on that monthly recurring basis, very similar to how we would have done the cohort program. However, on the back end, if that network is able to improve and achieve the metrics, there'd be a form of shared savings that would then come back to Care Compass Network for having prepaid those investments. So I'm getting very, very deep into this very quickly, but that's the mechanism that allows us to start to identify ways to use the district dollars to continue to innovate and impact high need measures for the Medicaid member, but also start to connect it into VBP funding sources. So we can go to the next slide here. I think I'm covering off on a lot of this. Yeah, we're talking about this is a glide path to risk. So in this model, CCN bears most of the risk because we're making the initial outflow financially. But this allows us to start to demonstrate the capabilities of the social determinants of health to move the needle on the clinical measures. And our hope and ambition would be that this is a pilot to prove the use case. And in future years, we might even start to see partners then getting into more progressive VBP contracts and maybe get into more upside or even downside risk arrangements, but we wouldn't expect that in the initial year. So we can go to the next slide here. These are the types of things that we might start to see here. In the district program, we saw gaps in measures that were given to CCN from the Department of Health. And there are ones that we got to know very, very well. There are ones like the PPR, potentially preventable readmissions, or the PPV, potentially preventable emergency room visits. We might start to see partners in certain contracts that have us now focusing on these sorts of measures, whether it's access to or completion of certain preventative visits, controlling of high blood pressure or prescription management, and these sorts of things. So there would be a lot of education and communication with partners about what are the opportunities and what do they mean. Some of these do have similarity and overlap with the previous measures that we had worked on, and some of these might be new. And so that's a piece of the learning about understanding and doing that connection between the social and clinical workspaces. So let's go to the next slide. I think this is where, yes, so I love whiteboarding. This one is helpful for me. So the mechanism here is that the MCO has a contract in place today, and this says regional health system. It can be a variety of partner types. It can be a health system or any other entity that has the VBP contract. So in this case, this is just an example here. The regional health system has $1 million worth of a contract that historically, year over year, that metric has not been met. And that health system and CCN collaborate to say there would be some sort of split, but CCN would organize a network to help address the metrics that are leaving that $1 million unearned by the health system. And so here you can see CCN has a portfolio of partners. This is such a well-represented group today. In this model, there's 4 agencies that are aligned to help move the needle with the measures for the regional health system. In some cases, and this is a rather large one, in some cases it could be a larger network, in some cases it could be a smaller network. I think we saw that with the cohort program with regards to the size of networks that were organized. But this is a way where the regional health system performs better in a VBP contract than they had classically year over year. And CCN is able to flow and distribute non-district funds ultimately over time to the community organizations. So this is the first, I think, illustrative draft. There's a lot of different ways that this could work. Alexa, let me go to the next slide here. Okay. This one, I think in the buildup and the framework has a lot of commonality, but a few differences from the cohort program. We could look at the first phase, and what we're targeting is to identify those opportunities with those VBP contractors today. And then once we've done that, maybe now through August, we can start coming out and advertising and soliciting the work to build the supportive networks. And that might take us another few months. And typically these performance contracts operate on a calendar year basis. So regardless of how long phases 1 or 2 takes, we would look to have engaged and integrated networks of care for these defined metrics up and running with defined funds flow models by January 1. So we're starting to have some conversations already today with potential VBP contracts that we can work on. So we are having some early traction on this, and we'll look to keep the partners posted about when they can start and all those different sorts of things. But we have to identify what are the opportunities, where are they, what are the metrics, and then we know more clearly how to do some of that secondary follow-up. So we're excited to get started. It is a little bit different. I think you can see from those of you that are familiar with the cohort program, but allows us to achieve a few critical pieces. Separate from this, we are doing a scope of work with Jason Helgerson, previously the New York State Medicaid director who formed the district program and has since gotten into a consulting business. And he looked at this pilot program last week and he said, this is such an innovative way to go through this transition process. So we always have the questions of permissible use cases for district dollars and also finding ways to move forward. But it was nice that Jason gave us that nod of agreement that, one, not only was it a permissible use case of the district dollar, but also a very creative and innovative way to start to build that bridging from the district program into a sustainability model and program. So that's the summary of the program. We haven't done a partner communication. This is the first time that we're releasing it. This was just approved Tuesday evening at the board meeting. Lisa, Bobby, and team are going to be working on communications to get these out to the partners. We'll be having more detailed discussions, I'd imagine, at future RPU meetings. But we're excited to have the next model coming out and having it come out in such a way that it's connecting into something. That's been the big piece about how do we sustain these services and things as we go forward. We can go to the next slide and I'll shift into some strategic planning updates. Looking at the time, I still have a few minutes here. Okay, so we've spent some time also, and a lot of this is very similar to what we did at the March stakeholders meeting. But for those of you that maybe weren't there or didn't have the chance to grab it, we're looking at shifting a lot of the engagement models that Care Compass does into open network activities and performance network activities. And events like today with bringing in guest speakers, doing regional collaboration, doing some workforce trainings even. All of this falls under the domain of the open network. So this is an illustrative graphic here, not just of open network activities, but the different organizational structures that we have to support them. So you can see we have Care Compass Network, the 501c6, supporting the open network activities. We've been doing this since day one. We want to continue to do it. And we're just trying to be thoughtful of the fact that as the DSRIP program ends and the title of PPS becomes more antiquated, a PPS is a lead entity for the DSRIP program. Now that the DSRIP program is over, the relevance of being a PPS is diminishing, and we're sort of changing that mantle to being the open network. So we want to continue to do these things, and I'll have another slide on that in a moment. We do have a separate entity that we formed last year called the Care Compass Collaborative. That is a 501c3 organization. Very happy to share that it did receive its C3 designation in April. And that's a granting division. It's very targeted and focused. We want to go after net new dollars to the region. We want to identify maybe some large federal grants or even find ways to support partners as subcontractors. So we've had a few opportunities where partners come to us and say, Care Compass with X and YZ system or certain staff or skill sets, can you support us on a certain grant? And we've been happy to do so. In other cases, we can have the collaborative apply directly for a grant and then bring those dollars and those missions into the region, and then subcontract with partners for whatever that specific purpose is. So we're getting a little bit more traction this year than we were last year with Care Compass Collaborative, and we'll bring more updates as we move forward. But we're also looking at Performance Network, and this pilot program I just mentioned is still engaged through Care Compass Network, but we're looking at getting into more progressive, what we would call performance network activities. It's maybe above and beyond the general engagement in the open network. And this is where we would have things in the future like performance contracting with CCN, performance contracting with a payer, having more progressive network management to achieve the performance of those performance contracts, and even developing and fostering the ability to get into risk, which we don't have an update for today, but there's a lot of whispers and rumors of a DSRIP 2.0 extension, which gets, from what I've heard, very heavily into advancement of VBP and risk contracting. So these are the main structures and components of the strategic plan, most notably the performance network and the open network. And you'll notice we have to find a house to put the performance network into. There's a lot of legal reviews underway about the permissible places to house such an entity, but we are going through that exercise with legal counsel. And the strategic planning work group has emphasized with us the need of urgency. And that's why we're happy to release the pilot program today, but we are still holding that matter and sense of urgency with the performance network, so we can also bring that to bear and find better ways to support the region outside of the distribution of the DSRIP dollars. I think we have one more slide here, and I'm bubbling up on my 2-minute warning here. So within the open network, it's a little bit further ahead in design and concept than the performance network. And this is a very helpful overview to see what are some of the features that are available to partners in the open network. And so when this rolls out, you'll see a lot of the similar things that we've been doing today. There are some things in orange here that are new. Things that aren't largely adopted by the partners yet. Some of these we've started to roll out in various RPU meetings, but there are a lot of opportunities available to partners through the open network. And what we've initially determined with our focus group was that CCN should make these opportunities available for free to the partners. Some partners were not aware of all of the different offerings and opportunities that were available. And we are in discussions with one partner in particular who's finding ways to even meet with our team and say, help me make sure I'm maximizing my engagement of all of these things, because it's providing a lot of support to us. So if you do have questions about anything on this page, access to data and analytics systems, or other ways to collaborate or have access to the results of all the past reports, we're happy to get these things with you and collaborate with you. There is a piece in here on the right-hand side, which is performance network readiness. And we recognize that maybe people want to be involved in VBP contracts or be involved in performance network activities, but maybe they don't know their readiness. And so we've built that into the open network where we want to help create pathways for organizations to get there. So it's not been lost, and it's something that we want to go through that journey together on. And more on that will be coming out as we start to identify and define what does readiness look like.